Hi, welcome to Dental XP and Happy New Year, everyone. I hope that in this year of 2013, we all get to learn a little bit more about what it is we do in complex oral rehabilitation, learn more and more how to improve our practices and to have less and less failure. Um, One of the great things about Dental XP is the amazing opportunity we get to all around the world learn from people that do what we do every day, and it's incredible, these new technologies. Um, Today I'm going to talk a little bit about one of my passions, which is the implant therapy and aesthetic zone, and what to avoid, how to avoid complications. And we're going to start with some of the big discussions that have been out there for the last decade, and why things today, I believe, are a lot easier and a lot simpler than they were when I started out. Now, it's always very difficult to talk to a large crowd uh, because you're going to have beginners and you're going to have experts, and I'm going to aim the level of complexity of this webinar to the middle of the bell curve. If any of you have more complex questions, feel free to get in touch with me, and I'm sure we can answer. So let's get started. So implants in the aesthetic zone, the reason why I would suggest they're probably the most complex are because the patient is acutely aware of any problem that can happen, seeing the margin of the implants, the transparency of the gingiva, so on and so forth. They're acutely aware of when things go wrong, and it's very, very difficult once that implant is integrated to correct the problems. So avoiding problems is the most important thing to do. So what's the fuss about? What has the fuss been about implants in the last decade? So let me filter that down for you. In the beginning, when I started out, or even long before, I mean, I started in 1999. In the beginning, there were several types of implants out there, and there was so many things to choose from that it was kind of difficult to know where to go. And you had each company had their own philosophy and their scientific data to prove why their implant was best. But what really got me was these major discussions, and I've been blessed to be able to go around the world and visit a lot of colleagues and see a lot of lectures around the world. And I would say that over the last decade, the biggest discussions were osseointegration versus fibrous integration. What kind of integration were we having? The shape of the implant, cylindrical, conic, what kind of implant was better? The surface of the implant. There was a big discussion for many, many years, and I think there's still a lot to come on this matter. Implant connection, internal or external, what would be better? Delayed placement versus immediate placement. When do we place the implant? What's the right time? And there are amazing studies to validate every single one. Immediate loading versus delayed loading. When to place the load onto your implant? What's the right time? What type of incision do you make? A full flap versus flapless? And of course, the healing period. So, osseointegration versus fibrous integration. Well, I would safely say that this discussion really is something that we don't need to stress about anymore, because we've got studies dating back to 1981 showing that there's direct bone to implant anchorage. Titanium is capable of creating a direct integration with bone. So this discussion was a very old discussion, but it was a very important one. And for those of you that are starting with implants, this is something that we can't overlook. Shape of the implant. Now, over the last decades, we've had so many different types of implants. We've had subperiosteal, we've had homemade implants, we've had these cylindrical implants, and the classic Brånemark implant, going now to the tapered implants with special grooves to augment soft tissue support. We can actually see, look, this cylindrical implant, this hollowed out implant here, these things integrate perfectly. This, of course, is due to several factors, but of course, we know titanium integrates. So once again, the shape of the implant has been a very important discussion. But I would say that the evolution, something that is very important to pay attention to, is evolving to more and more natural shaped implants. So, of course, conical shaped tapered implants. So once again, the actual debates and benchmarking that the industry does is pushing towards the same way the automotive industry, there was a first company that came out with ABS, and all of a sudden every single car had to have ABS. So excellence and good results and better results are benchmarked across the board from all implant companies. So I'm thinking and I'm seeing that most implants on the market today tend to be tapered. The surface of the implant. Now, of course, this is probably one of the biggest debates nowadays today. And, we have here on the left the classic machined surface implant. I placed hundreds, if not thousands, of these implants in my early years, and they're still completely integrated in the mouth today. But we know that rough surfaced implants, they tend to have better results nowadays. Just the same way, if you think about it, as the digestive tract has those has a looped surface to augment the surface area. If we have etched surfaces, we augment the adhesion of cellular. We augment the surface area for that osseointegration. So once again, we now know that we don't want to coat these implants, that we want to make these roughened surfaces that augment the area. The connection of the implants. Initially, we had the external connection, and today, more and more, we're going to the internal connection. Different brands have different types of connections. And one of the things that these internal connections allow for is platform switching. I'm not going to get into platform switching today. There's a lot of great lectures out there on the subject, and I suggest you look into it. And of course, you've got the cone-morse connection. This is the new C1 implant of MIS. It's a lovely implant that we're doing some investigation with now. But once again, every year, new things come out, and I always like the analogy with the automotive industry or the airline companies or even computers. Every year, of mobile phones, there's always something new coming out, and that advance in technology is there to make our life easier and simpler. So once again, we tend not to stress about these things. The immediate placement versus delayed placement. I mean, when is the right time to place your implant? Well, I would probably say, that immediate has advantages and disadvantages, as does the delayed. If we look at the immediate, it's a faster surgery. We've got maintenance of soft tissue. The patient much prefers the immediate implant. I mean, who doesn't want to take their tooth out and go home straight away with an implant? The disadvantages are, of course, if you have a previous infection, you can have some infection, and you can't always place the implant in an ideal position. With delayed implant, we have more control, we can do grafting, less risk of infection, it's more predictable. Of course, the disadvantages for the patient are time, and the patients much prefer, they always tell a story saying, oh, well, can't you take it out and put it on the same day? It's almost like a badge of honor if a doctor can do this. Once again, you really have to use your head on this. Of course, we can't do immediate placement when we don't have enough bone. So in this study from Fonato, 2007, where he classes different types of buccal bone quantities, and he says, if we have deficient bone, the implant placement may deviate. So it's unacceptable to place an implant in these conditions. So we tend to, some people tend to actually reposition an implant in order to get that primary stability, and that's a mistake. So if you can't get your implant in the right place with the right angulation to allow for a correct restoration, do not place your implant graft, and wait. So once again, this has to be planned and factored into the treatment planning and not something done just on the spot. So, of course, CT scanning and a good patient diagnosis and clinical diagnosis is very, very important. So, immediate placement or delayed placement. Use your head. Be cautious. For those of you that are beginning, and especially in the aesthetic zone, it's always best to wait if you can get a better placement of the implant. It's very few other parts of the mouth is the correct positioning of your implant as important as in the aesthetic zone. Immediate loading versus delayed loading. I mean, when can we load our implant? So there's the classic, if you've got the right torque for this implant, if you feel comfortable that this patient is not a grinder and the patient doesn't smoke and has a good oral hygiene and the occlusal forces are not all there, then, I would suggest that you can place an immediate crown. But I mean, if it's out of the aesthetic zone, for example, a molar, there's no need to place a crown on that straight away. It's out of the aesthetic zone. It's best to wait. Plus, we know the occlusal forces, the biting forces, are a lot greater at the back of the mouth. So what I'm trying to say is in the aesthetic zone, if we're going to be placing an implant in the front tooth, in most cases, if the patient has all of his posterior teeth in good occlusion, and we can place an immediate crown like you have here, a temporary crown, and I'll show you this case later on, as long as that crown is out of occlusion in every single position in the mouth, and the patient has a soft diet for the first 6 to 7 weeks, then we can assure that, in all likeliness, this implant will be successful. But, you've got to use your head here. You have to evaluate carefully all the pros and cons, and you don't want to jeopardize your treatment. If you don't get that right torque, for example, if you can't place a long, wide-bodied platform implant, and you have to use a thin, narrow platform for a large tooth, that implant's not going to give you the same stability as a wide-bodied, long platform. If you only have 9 millimeters or 8 millimeters of bone, which of course is rare in the aesthetic zone, and you have a narrow-body platformed implant, maybe you might want to wait a little bit before you load that implant. So once again, you have to use your head here. There's no better judgment than your own in feeling, how strong was my insertion torque, and can I trust that this implant will be successful? All right, so there's a lot of things that have to go into consideration when you're doing this. Now, the type of incision, full flap versus flapless. I like both. I use both. There's no one that is better than the other. I mean, if you raise a full flap, you can see everything. You can see all the defects. You can graft. It is, however, more invasive. You have more swelling afterwards, and if you can, like on this image on the right, go in and use a flapless technique, it's less invasive. You can, the patient acceptance is huge, but you do have to have a little bit more experience and probably have to use a surgical guide to get that implant in the right angulation, because otherwise you'll have some perforation of the buccal plates, because there's nothing better than seeing what you want to see. So there's no perfect solution for what type of flap you should use, and both are highly valid. The healing period, this is something that's very, very important, and we know that if you are going to load your implant, the primary contact, bone contact, is highest, as you can see here, in the very, very beginning. And as new bone starts forming, that secondary bone starts forming, it's only after about 7 weeks, 6 to 7 weeks, do we have good solid bone again. So the ideal time for loading is immediate, will be in the first, week. Otherwise, leave your implant alone till about 6 to 7 weeks after you've placed it. All right. I remember when I was placing implants, I used to wait 6 months. Nowadays, with these new implants and more confidence, and as you grow in your career, you can feel more confident about these time frames. So I would say I'd either load in the beginning, right on the day of the surgery, but with the teeth out of occlusion. Remember, we're talking about the aesthetic zone here. I would place these implants out of occlusion, Or if I have to wait and do delayed loading, I will wait at least 7 weeks, sometimes 8, just for that extra security before I load my implants. So, what do we need to know here? Well, before we take on these complex cases in the aesthetic zone, we need to understand anatomy. We need to understand the angulation of the anterior teeth. We need to understand, that there is a concavity here, and that concavity can lead to a lot of problems in the aesthetic zone. All right. So when you're placing your initial burr, you feel how compact that bone is. Bone density is also very important. So there's several factors here. There's the bone density. Is this thick, dense bone, or is this very soft bone? All right. Once again, how much of bone do I have? Because the choice of implant is so important here. The wider, longer implant you can place, the better outcome you're going to have. But you don't want to have your threads showing through here. So angulation is very, very important. Also, we need to understand what happens after tooth extractions. We know that, Homle Wang, and we know back from studies of Amler in the 60s, that there's about 50% of bone loss in the first 12 months after a tooth extraction. Why is this so important? This is important because immediate placement is always beneficial, because we don't want to be losing that very precious buccal plate that we have, that very thin buccal plate we have in the anterior zone. So this is also something that we need to keep into consideration. So when we are doing implants in the aesthetic zone, we need to understand the smile line. Do I have a high smile line? Meaning, am I going to see the entire gingiva surrounding my teeth? Because, if you have a high smile line, you don't really have any forgiveness. If you make a mistake here and you create bone resorption around the implant, and consequently gingiva remodulation, you're going to have a very nasty aesthetic problem in this area, and you will lose that patient. And with the correct planning, you can avoid that. We also have to understand the biotype. How thick is my bone? What kind of soft tissue do I have? The thicker the biotype, the more bone we have, the more soft tissue we have, the easier it is to get a predictable outcome. Also, the quantity of papilla, the thickness of the facial bone plate, the long axis of the adjacent teeth. All this information is vital when you're doing implants in the aesthetic zone. It's not as easy as doing it in the back area, which is a lot more forgiving. The angulation of the implant is very, very important. Now, depending on what country you're in, I know that in the US, usually the periodontal surgeon or the oral surgeon will place the implant, and then you have a restorative dentist that does the restoration. In Europe, this is different, and I think the trend is changing, where it is the dentist who places the implant and does the restoration, the same person. Why do I think this is important? Because, well, it's easy to place an implant. It's not easy to place an implant in the ideal position. It's not always easy to place it in the ideal position, especially if you have limited bone and, it's after an immediate extraction. However, the implant should always be restoration driven, allowing for an ideal crown to be placed, and it should be in the center of the tooth it replaces. Now, not always do we have the ideal quantity of bone, meaning the surgeon will place his implant in a different position other than ideal, because he wants to get that implant placed, and then when time comes along to place the crown, the restorative dentist will have his work cut out for him in this case. So what we need to know with implant placement in regards to its buccolingual position is that you should always place it as palatally as you can to preserve this buccal bone plate. Now, this is not always possible, but if you have a very thin buccal bone plate here, what might happen is resorption of this bone plate, and if you have a thin biotype, you can see the gray of the implant through the gum, and this can create an aesthetic problem for you, and patients really don't like that, and these problems are quite difficult to fix. So always maintain at least 2 millimeters of bone thickness on the buccal plate. And if you, of course, place it too far back, then you will require a ridge lap restoration, and that's very unhygienic and unaesthetic. So try and avoid these problems. If you're a beginner, surgical guides can help you with this. If you're not, and you've done this a lot, then you'll agree with me that this is one of the most important things. Regarding the mesiodistal position of implants, there's some great studies out there, and we know basically that you want to keep a minimum of 3 millimeters in between the necks of two adjacent implants. If you reduce that space, what's going to happen is that you're going to have bone resorption in between the two implants, and consequently you will lose the papilla. And if it's a lot greater, you won't have enough bone height to create the papilla. So there are ways of getting around that, but ideally you want to keep it a minimum of 3 millimeters. Regarding the depth of the implant, the apicoronal position, you want it to be as shallow as possible and as deep as necessary. So, the more into the bone you place your implant using countersinks and so on, you will have more soft tissue to play with. However, excessive countersinking, you can lose the bone, and this doesn't happen immediately. It will happen over a period of time, leading to the loss of the papilla in between the adjacent teeth. So it's very, very important that you actually do this in the right level for the implant you're using. So different implants, different heads of implants, different shapes and types require different positioning. Once again, the importance of the interdental papilla when you place your implants. Salama, my good friend Salama, his family are legends in the industry. They came out with a study that basically was a further insight into a Dennis Tarno's study of contact points between two adjacent teeth for the presence of crestal bone. And they took that a lot further into seeing what happened with predictable height of interdental papilla between other components. So we know that if you want to have papilla between two adjacent teeth, the height of the crestal bone to the contact point shall always be equal or inferior to 5 millimeters. But that wasn't true for tooth to pontic, pontic to pontic, tooth to implant, implant to pontic, or implant to implant. The height between adjacent implants is 3.5, and it can go up to 6.5 in between tooth and pontic. This study is incredibly important for those of you that understand the importance to obtain a good gingival result and aesthetics. So how to rehabilitate? Once again, in the aesthetic zone, if we have 4 missing maxillary incisors, how many and where should we place the implants? So, we can look at these 4 different images here and say which one's ideal, which one's not. So for those of you looking at this image, you can all make the different choices, and probably the top left on your screen, having 4 different implants, individual teeth. A lot of patients say, I want to have individual teeth. But if that patient doesn't have enough bone to allow for a good 3 millimeters in between his implants, you won't have a good overall aesthetic outcome. What is the ideal solution here? Well, if we're placing 4 implants in the anterior region for individual crowns, it's a very high aesthetic risk. You really have to have good biotype here, thick biotype, and these implants have to be placed in an ideal, absolutely ideal position. Have to be very good implants, good quality, good surface, have to be placed in the ideal position to guarantee that you can get a good aesthetic outcome. For a very low aesthetic risk, we have just 2 implants placed in the area of the laterals and you'd make a 4-element bridge. So I would say that this on the bottom right would be the lowest aesthetic risk, and probably what we choose to do most times. And this is, I'll show you cases where this is the option that we chose the most. Of course, we have surgical guides. For those of you that don't know, there's a lot of companies out there, and the company I work with, MIS, they have an incredible solution for this, and there's a lot of them out there. So speak to your local lab and have them help you with this, and have your local implant rep come and talk to you about how to make these guides, because in the aesthetic zone, they really, really help. So if you just log on to the MIS website, you can see how this technology is easily available. But how can we avoid planning, having a beautiful aesthetic outcome, and ending up with, very, very complicated failure? It's what I've just been talking about up till now is important scientific data and important discussions that can avoid having problems. But, from theory to practice, we all know that there's a very big divide. So we might have the right ingredients and choose all the right tools, but not always have the best result. And, if this is fortunately not one of my cases, this is a textbook case. And, I'm sure the surgeon did everything right. But if we look at that, these are quite old implants, and we know stuff about these implants today that we didn't know 10, 15 years ago. So, this is probably very, very good work, but the biology and the mechanics of the case, we didn't know what we knew, when this case was done 15 or even more years ago. So, thank God that the evolution of the industry and what we know today is all aiming to avoid having these problems. So what do we do? Well, we need a good, what I call recipe book, to help us cook the right ingredients the right way. And that, of course, is the science and all the evidence out there. We need to choose our cases correctly. We need to plan it correctly. How? 3D scanning, cone beam technology is more accessible nowadays. Get to know exactly what's inside the bone before we even do our first incision. We need to choose the right implant, and of course all the necessary materials around that implant. I can't equate placing an implant today without considering bone grafting. So it is fundamental for those of you out there that don't have good knowledge on bone grafting and immediate placement to understand this if you want to have success in the aesthetic zone. This is super, super important, so you can have what we call those invisible cases and long-lasting success. Because if you don't have this, it's probably best to stick with what you do know, because there's a lot of competition out there, guys, and it's really, really important that we focus on quality and giving our patients the best. And if we can't do it, then we have to be ethical here and refer. So this is a case that came into my clinic a couple of years ago, and this is a perfectly good implant, but I can't for the life of me understand why anybody would want to place an implant up there. So we also have to try and avoid doing this. And I asked myself the question, why does this happen? My clinic over the last years has become more and more a clinic where we receive cases, failure. We've received a lot of cases that have gone wrong. Colleagues, they call us up and say, could you help us out here? Or even just patients that are sick and tired of not being given what they think is the correct treatment planning, and they come to us. So the emotional charge of these patients is huge, and the complexity of the cases is immense. And it's no fun to try and clean up someone else's mess. And I try to ask myself, why would anybody place an implant up there? It's a mixture of several factors, I believe. So everybody who's been following my work knows that I'm a big fan of this no half smiles philosophy, which is there's no halfway to do a good job. You have to either do a good job or just stay home and don't do it. You can't plan to do complex aesthetic oral rehabilitation and only do it half-heartedly. So how do we manage these different cases? And why do these problems happen? Well, I was thinking the other day about Lady Justice. And here's the image of Lady Justice, and she's holding a sword, she's blindfolded, and she's got a balance. And in my head, it was just very clear that a lot of us out there, uh, we we are blinded, by what I believe is a financial obligation to have a successful practice, and sometimes this blinds our judgment. And if we look at this image here, I would say that the sword that she's holding is our skill levels, and we have to be very honest with ourselves, and we have to know, can we do this? And it's legitimate for any man or woman out there to think that I can do this. I'm good at this. And as surgeons, we're trained to take things as far as we can go within science, within the evidence, and we shouldn't push that more than our capacities. But as human beings, most of us tend to think that our sword is a little bit bigger than it is, and that's why, unfortunately, so many mistakes happen. Excess confidence, just believing that we're better than we are. And when you're doing implants in the aesthetic zone, there's not really much margin for error. And thankfully, there's so many amazing surgeons out there, but a few of us tend to think that we can, do things and not plan it correctly. And I just say that excess confidence can ruin lives. Um, the balance is a good case and a bad case. Now, I've been lecturing for a good 7-8 years now around the world, and I've been to over 27 countries. And whenever I ask this question, I always get the same answer. And I say, what's a good case? And people go, oh, good cases when you've got a lot of bone and, there's no infection, so on and so forth. And a bad case is when you have no bone and you have infections. And a lot of doctors tend to go straight to the clinical aspects of a good case. Well, I would say that a good case is where you have an amazing clinical condition, so great biotype, thickness of the bone and soft tissue, healthy patient, doesn't smoke, no pathologies, very compliant, very nice person. But for me, a good case nowadays is a nice person, is somebody that understands and cooperates with you as much as possible, that understands the incredible delicacy and intrinsic difficulty of doing a case like this. A bad case is somebody who doesn't really talk, who's not really compliant, that doesn't show up for appointments, that doesn't brush their teeth, that just generally not a nice person. Because let's say if you have a great clinical condition, so the good bone and so on, but the person is not an easy person, or you have a very difficult clinical condition, so very little bone, but a very nice person, which one would you prefer to treat? You should always ask yourself this question. So I would say a good case is when everything in the mouth is perfect and the person is a very nice person. Because if you fail, if you have a mistake, if you make a mistake, and we all make mistakes, then dealing with that mistake becomes easier. If you have very little bone, very little soft tissue, smoker, pathologies, and the person on top of that is not an easy person, I would safely say stay away from these kind of cases, because if anything goes wrong, it's a perfect nightmare. And remember, guys, put your greed away. Everybody likes to have a successful, financially profitable practice, but we all know how much we lose when these cases go wrong. So to know yourself, your skills, and your patient, and your predictable outcome will determine success. Success is the delicate management of your greed, your skills, and your patient's desires. And don't go in blind, guys. Do your homework. It's not just a question of sitting down and shooting from the hip. No matter how good you think you are, it's so important to know your patient. So you got to know the case. Do your clinical studies, take x-rays, CT scans, but also know your patient, not just the clinical aspects. Is this a nice person? Is this an easy person? Because you want to know, if something goes wrong, how difficult will this patient make your life? And you've got to know your skills. It's super important. I can sit here for hours, like I've just started my presentation, explaining the major discussions, different choices that have to be made. And there's a lot of science out there to base, the evidence of where you should place your implant, how you should place your implant, when you should load it, so on and so forth. That's like a rule book. We know that. But if you are not skilled enough to do these cases, and you do not know your patient, and you do not know your case, you will fail. And in 2013, guys, I don't want anybody out there failing, all right? This has to be a year of success for everybody. Different cases require different skills. So if you're going to do a complex rehabilitation, you need to be a skilled surgeon. And not just you, you have to have a good lab. You have to have good co-workers. The whole team has to be on board here. Maybe you need more than one person to help you with this. If you're doing simple cases, then of course, simple skills. You don't need to be too complex about this. And you've got to know your team. Us here in Portugal, we're a big fan of football and soccer, as we call it here in, soccer, as you call it in the USA. And we produce some of the best football players in the world. And I think sometimes that, if we think about it, if you're going to go and do complex rehabilitation, you need to think like a football team. You need to think like, why are some teams so much more successful than others? What makes some teams consistently win more prizes than any other team? Well, strategy, of course. You have to have a good goalkeeper, good defense, so on and so forth. And in oral rehabilitation, no matter how good you are at implants, if you don't focus on the oral hygiene of your cases, you're going to have some failure. What about endodontics? I see a lot of great implants placed to teeth that are that have poor root canal next to them, and that infection from the tooth adjacent will affect that implant. So the importance, and this is my philosophy of No Half Smiles, the importance of having everything taken care of. No matter if you just have a good attack and no defense, you're going to lose games. So once again, strategy is important. So oral hygiene. People might think, well, we're talking about implants in the aesthetic zone. Why is oral hygiene so important? Because I have seen cases fail because the doctor, the surgeon, neglects the importance of having your patient come in periodically to do constant checks-up for oral hygiene. This is so important. Bacteria is the #1 cause for periodontal illness. Everybody knows this. But sometimes we forget to do that. So when your patient comes in to do their implant, make sure that you already have their subsequent 4, 5, 6 follow-up checkups to do their oral hygiene. Bring them in and take your x-rays when they come in to do their cleaning. It's so important to get this done correctly. Endodontics. Now, as an implant surgeon, I'm a big fan of placing implants. However, nothing substitutes a natural tooth. And as you can see this image in the middle, this is a premolar that has 1, 2, 3, 4 canals. And I'd like to congratulate Dr. Carlos Moraes from my team. He is relentless when it comes to getting a good job done. And, overall, in the aesthetic zone, nothing is better than the natural tooth. So had we not done a good root canal on this tooth, who's to say that an infection from the base of this tooth could have spread to those implants? And if you place those implants at the same time, you can lose implants this way. So every single thing starts counting. And no matter how bad these teeth are, if you have good endodontists on your team, you can save teeth, you can save your patients money, you can save them time. And this is so important, I would so much prefer to save a patient's tooth than an implant any day of the week. You can see some excellent endodontics, and I hope that Dr. Carlos Moraes soon will be putting up some lectures on Dental XP as well, for those of you that are fans of endodontics. Of course, even aesthetic dentistry, because down the line, imagine you have a crown that cracks on an implant or chips, to have somebody on your team or even yourself that can restore that, because patients, a lot of them, they don't understand the difference between the crown and the implant. They think it's all one thing, and the importance of aesthetic dentistry is important. Of course, orthodontics as well. And the reason why I'm talking about orthodontics is because we use orthodontics a lot to create soft tissue in the aesthetic zone before placing implants, and I'm going to show you quite a few cases of that in a bit. So, you know, all of us have that, you know, VIP patient in our neighborhood, and sometimes we get really, really happy when the mayor comes in town, or, you know, the somebody that's a big businessman in the neighborhood. You know, if you place an implant in the aesthetic zone with a very powerful individual of your community, and that case goes wrong, what do you think is going to happen? So, guys, we really have to try and avoid these kind of situations. So what you communicate to your patient is very, very important. Different cases will require different materials. And I'm going to just briefly run you through some of the materials that we use at White, because I find it as important as the implant we use. Now, in the last years, I've been to almost every single dental convention around the world, and you can see that more and more all of the big stands in the dental trade shows are implants, because, you know, that's the big moguls of the industry. And, you know, there's dozens and dozens of implant companies, but I haven't really seen anybody discuss the importance of the impression material when it comes to bone around the surface of the implant. And I would like to actually take some time to talk about that, because imagine you do a perfect implant, perfect soft tissue, you've done everything well, and then you go and take your impression with a cheap impression material. Something that is not entirely faithful, something that has a lovely flavor, that sets in under a minute. It's very comfortable for your patient, but it's, let's say it changes its microscopic structure with heat or with temperature or with moisture in the air, so on and so forth. The lab's going to get that work, make a crown after running the dye, and that crown's not going to fit perfectly onto your implant. You know, and I don't know how many of you have, you know, send that back to the lab. I know a lot of dentists that will just grind that into place and cement it on. Now, what happens, you're going to have a micro gap between the crown and the head of the implant. What's that going to do? That's going to create plaque buildup. That's going to create inflammation. You will lose bone around the implant, consequently gingiva and soft tissues. All because you decided to use an inferior quality on your impression material. So, you know, it's easy to sit here and discuss the importance of implants and placement and so on and so forth, and overlook something as simple as the quality of your impression material. And I have been using Improgam for 12 years, and it's a highly stable product for taking impressions over implants. And I just don't use anything else. And for me, this is something that is so, so vital to the overall outcome of implant. The quality of the cementation materials. I always use this product here, which is self-adhesive universal resin cement. I never use temporary cement to cement my crowns. You know, I've seen so many people that always use a temporary cement, and sometimes these crowns pop off. And we are going to discuss screw-retained versus cemented in a bit. The importance of the quality of the ceramic. I like to use IPS Empress. We're using new Emax since it came out. Very, very good quality. Even the using digital X-rays. Our clinic have been digital for 11 years now, and the importance of being able to take several X-rays to make sure the adaptation of your crowns is okay, something that's so important. And as I was discussing just now, you can see just over natural teeth, the adaptation of our crown to the natural tooth, that has to be the same on our implant cases. Otherwise, as we saw, we can have problems down the line. Once again, as I said, the cone beam technology is more and more available. If you don't have it, try and find a local clinic or hospital near you that will allow you to have this technology. Because if you are going to work in the aesthetic zone in the 21st century without a 3D image of where you're going to be placing your implant, it's not a good thing. And of course, the implant that you use, I am exclusively placing these MIS implants now. They have two great versions. They have the MIS 7 implant, which is what we're using primarily, and the new C1 implant, and we're doing a study on that, and I hope to be able to share that with you here on Dental XP as soon as possible. Also, the regeneration materials, the quality of your regeneration materials. I'm a big fan of this product. And this is also a very, very good product we have here, which is calcium sulfate. Membranes. As I say, these collagen BioGuide membranes, for those of you that are into guided bone regeneration, I've been using these membranes for a very long time. And in the last year, I've hardly placed any. Reason, because there's a new product out in the market, which I'd like to discuss, which is this Bond Bone made by MAS. And it's just an incredible product. And I'll be putting up a webinar very soon on the qualities of this product. Now, let's talk about strategy. So, when the patients come in with very complex cases, the way that we like to discuss this with the patient is to compare it to rebuilding a ruin. So, first you see the ruin, you project the future, which is like what an architect does. Then you start demolitions, you place the pillars, raise the walls, finish the case, and decorate. I think every patient in the world can understand this analogy. I want to take this back a little bit. Look at that ruin over here on the left. How many of our patients ask to just do one part of that ruin? They come in with a mouth that is completely destroyed, and they just want you to do the aesthetic zone. Why? Because, of course, the social impact of a smile, so on and so forth. And then you say, but you need to have teeth at the back as well. And they're like, oh, no, it's because, they're thinking cost, they're thinking too much money, too much investment, too much time. But, it's the same thing when our patients ask us to just do the aesthetic zone and not to worry about the functional posterior region, as somebody asking a contractor to just, look, I know the house is in ruins, but could you just do the kitchen? It's the same thing. So patient education is very, very important. So, what do we do in these cases? And I think the solution is not technical. It's in the management of the therapeutic process. And there's some lectures of this already on Dental XP. And I believe the philosophy here is no half smiles, because we don't just place implants. We don't just treat cavities. We don't just do crowns and veneers. We don't just do orthodontics. And we don't build half smiles. We create smiles, and a smile is seen as a whole. And as you've seen before, with these implants in aesthetic zone, it's not just about the implant. It's about the positioning of the implant. It's about the surface of the implant, the connection of the implant. It's the quality of our impression material. It's, the treatment planning. It's the torque of the implant. It's deciding if you're going to load it immediately or delayed. So many decisions have to be made at that critical moment when you treat your patient. And it's every single bit of that will determine your predictable outcome or success. So the way we do it in our clinic is that we do a complete treatment plan and, a quote, and we tell our patients, you stick to this plan and things will work. And it's pretty much all or nothing. I cannot consider doing only an aesthetic rehabilitation with implants in the anterior region if my patient has no teeth in the back. Why? Because it's not going to work. Something will fail. And I prefer to not work than to do this kind of rehabilitation. So how does it work? Well, for those of you that are starting out, I'm going to do a little bit of an analogy with an aesthetic case and then a implant case. So this is a case that we had no implants. This patient came in. He's a TV presenter. And basically, he had an aesthetic problem that should have been solved with orthodontics. He had some old crown work, had some old composite bondings on his teeth. He was missing some molars. He had some old amalgams. And his major concern here was aesthetics. And we suggested a year and a half of orthodontics and placing an implant in the missing area. He said no. He asked for a more immediate aesthetic solution, and we complied with this, and we gave him some crowns and some veneers and a little bonded bridge work here. And we rebuilt his smile. We didn't need to go to the posterior regions here, but we had good occlusion at the back. Everything was in order. And because we kept to the occlusal principles, on a 4-year follow-up, you can see that we have incredibly stable results. Why? Because everything was done at the same time, but most importantly, we took care of occlusion. How good do you think that these results would be in the aesthetic zone if this gentleman had no teeth in the back? They would be chipping, they would be breaking, something would have failed. Now, these same principles apply with implants. So this is a patient who was a very, very, very big bruxer. She had lost a daughter 20 years ago, and she had a lot of stress in her life, and she'd grinded all her teeth down. So our treatment planning for her was basically endodontics on these anterior teeth, post and core buildups, and rebuild these with some crowns. But had we not placed these implants in the posterior region, she wouldn't have been able to have a proper occlusion, and she would have transferred all that stress to the anterior teeth. A 3-year follow-up. Everything is in the mouth. There's no chipping. There's no problems. There's no way I would have had these results had I not placed these posterior implants and given her an overall functional occlusion. There's no way I would have had these results. So the importance of getting good anterior results, long-term results, and this is not a very long term, but I just wanted to show you that full ceramic crowns on a case like this would have been impossible had we not had posterior function. So let's go to the second part of our presentation. Let's walk you through some easy cases. So here we have a gentleman who's had some mobility on a central incisor. As you can see, he had some periodontal inflammation. He'd already had a apical surgery done some years ago, but this tooth basically had failed. But look at the quality of his soft tissue, hard tissue. This gentleman had a very thick biotype. So very comfortably, we extracted that tooth, cleaned everything out, and placed an immediate implant. This is the MIS 7 implant. It's a 4.2 platform. I believe it's a 13 millimeter implant in the aesthetic zone. The positioning of the implant here is ideally positioned 2 millimeters from the buccal plate, as I explained in the beginning of this lecture. Now, I had a 45 Newton insertion torque. I had all his teeth in occlusion at the back. I had a good posterior occlusion. I knew that if I placed my implant with a good torque, I have a nice 4.2, that's a good dimensioned implant, a long implant with a good insertion torque, right? I have posterior occlusion. I felt comfortable to do immediate loading. So here we have this is a temporary abutment. It's an acrylic abutment. We screw that into place. This is some flowable composite that we just inject and light cure around that. And I have my initial alginate impression before the extraction. I inject some cold cured auto cured Voco. This product's called Structure from Voco, composite resin. That takes about 4 minutes to set, and I open a little hole in the back of the crown and unscrew the structure, polish everything, make sure that everything is nicely contoured, not too wide, and I screw that crown into place. Now notice it's a bit shorter than the adjacent teeth. Why? It's completely out of occlusion in protrusive, in lateral left and lateral right, excursive movements. There is no pressure on this crown in any way. We tell the patient to have a soft diet for the next 6-7 weeks because we saw that the bone remodulation will take that long. Now, notice I place my implant at bone level in this case, and we can see immediate post-op photograph. We also placed another implant at the same time. There was absolutely no suture given at this time. Waited a good 8 to 9 weeks. Look how the soft tissue has been prepared. That emergency profile has been designed due to the contouring of the temporary crown. And we place an impression coping, take our impression, make a zirconium abutment for better aesthetics. And this is on the day of placement. We take an x-ray to make sure that the adaptation is right. Remember what I said about Improgam, the importance of the adaptation here is so important. You can place the best implant in the world, do everything right, but if that crown doesn't fit properly, you will have problems. And at the same time, following our principle of no smiles, we rehabilitated these back teeth, placed a bridge, placed a crown on that back one to get some good posterior function. And I know, because I've got my posterior function, that this crown at the front will have a good overall and long-term predictable results. I think this is after about 2 years. Here we can see very stable results. Once again, why are they stable? Because I have posterior function. So you can't consider any aesthetic anterior rehabilitation with implants if you do not have posterior occlusion. So let's look at a case that I did in 1998. I rehabilitated this gentleman with some crowns and veneers in 1998, and this is my work. As you can see, we did from first premolar to first premolar. And I would say, actually, you can see here the actual, because of the good adaptation, it's a good result after almost 13 years. But the gentleman had an accident, and his anterior two centrals, one was suffering from internal resorption, and the other had a periapical lesion here. Now, we tried to do root canal, but the crown was completely calcified. So we spoke to him and said, listen, most probably going to lose the two central incisors. The gentleman was very upset, but with good treatment planning, we convinced him that he would have an equally good aesthetic outcome. We took out those two crowns and the corresponding roots, cleaned everything up. I raised a little flap here because I wanted to make sure that I could get rid of all that lesion there and do some proper direct grafting. You can see we placed implants. We placed the MIS7 implants, and this is BioOs mixed with bond bone, and I'll explain that just now. The calcium sulfate, bicalcium sulfate, which is an incredible binding agent that heals, that sets in the presence of blood and saliva, and has a neutral pH, and sets at 37 degrees, the body's temperature. It's an incredible product from MIS. I went to the tuberosity with the circular bisturi and got a little bit of soft tissue. Why did I do that? I deepithelialized it, taking off the keratin layer, and I used that just to puff up my soft tissue and get a little bit more of density there of soft tissue. You can never have enough soft tissue in the anterior region. And I packed a little bit of the excess, the BioOs and bond bone that I had around the site, because one of the advantages of this product, that you can actually, it does set in the presence of blood and saliva. Here you can see the second soft tissue grafting in the buccal area. This is just an idea that came up at the time. This is a blockout gel that I use when I'm bleaching teeth. So the same system, I'd had an initial impression, and we filled that with the composite, waited 4 minutes, unscrewed it, and did the conturning, making sure that there was it wasn't too thick around. This concavity here allows for a better soft tissue volume, and also respecting the contact point to the crestal bone length there to make sure that we have a papilla being formed. We screw this into place. I prefer screw retained any day of the week over cemented in these initial cases, because like that I've got no cement extruding into my surgical site. Once again, no suture, as you can see in this case. This is not always the case, but in most cases with immediate extraction, placement and immediate loading, I do not place any suture. Why? Because I use the right, we gauge the right size of the implant, and of course, if you do an atraumatic surgery, the volume and dimension of the crown should be that of the pre-existing crown. Hence, it's unnecessary to place suture. But of course, if you feel more comfortable placing suture, please do. And as you can see, the teeth are shorter, out of occlusion, and this is after 1 week. We can see all that soft tissue is healed. And you can see we did place the BioOs with the bond bone, and look, there's no inflammation. This inflammation is, of course, of the removal of that infection he had there. Sorry. This is after 9 weeks. Look at all that soft tissue that we got for placing that grafting there. These are the impression copings of the MIS system, color coded, very simple, very hard to make mistakes with this. These are the impression copings. They allow for ideal visualization from the lab. And as you can see here, you get a perfect impression every time. We send that off to the lab. Because we had so much thickness, zirconium abutments weren't necessary. This is just some opaque on a UCLA abutment. We screwed that into place and cemented the crowns. A bit of blanching for up to about 3 to 4 minutes is normal, but it should go away after that period of time. Everything into the right occlusion and the restoration in only 3 appointments. Gentleman was quite happy. By following the protocol, by following all the right rules, all the scientific data, you know that this is going to be a very good predictable outcome. I am not worried because I know that we did everything right, and you can trust the bibliography, the literature. If you trust the science, you will have good outcome. But remember, I used all the right products. I didn't cut any corners. Despite the speed that I did this with, I cut no corners. We did everything according to the rules. Another gentleman, Jacques. This is a bit more of a complex case. Look at the, despite looking like a very difficult case in the aesthetic zone, we have very thick bone, but very thin soft tissue. By having very thin soft tissue, there's 2 things I can do: is either graft soft tissue first, wait, and then place my implant, or I can just discuss with this gentleman using pink ceramics. Now, I'm a big fan of pink ceramics in these complex cases because it's just easier, and if you've got a good lab that can create a good overall aesthetic outcome, it can help a lot. So sit with your client, discuss this with him. If he's okay with it, then it saves a lot of time and a lot of stress, because getting an ideal soft tissue contour in a case like this and the presence of papilla will be virtually impossible. Once again, no matter how good you are not better than the science, you are not better than the biology. So the more you know about your case, the more honest you can be with your clients. I told my client up front, I said, look, no matter how good I think I am, I'm never going to get natural soft tissue here. It's going to be a nightmare. So let's just keep it simple and go to pink ceramics. He liked my honesty and he said yes, and I relaxed because I knew, I had a lot more leeway in this case. So here we go. On the day of the surgery, we knew we had a lot of bone, but on one of the quadrants, we had very little bone, and we see here, and that's the importance of the cone beam technology here, that I was going to require a sinus lift. Now, a little trick: when I'm placing implants, I will place always the easy implants first. Why will I place the easy implants first? For harvesting bone. And one of the great things about this MIS system is that each implant provides you with a final burr for the osteotomy, and it's one of the best bone trephinds I've ever seen. And I'm going to show you how we do it. So we start with the easy implants, and here I'm doing a tissue punch technique, and as I discussed in the beginning of my lecture, it's a decision that's up to you. I could have raised the full flap, but I had great biotype. I'm confident about my capacities in orientating these implants. I also did not use a surgical guide, but once again, I've been doing this for many, many years. For those of you that are starting, a surgical guide would probably be a good idea. So we place these implants. Once again, MIS 7 implants, wide body 4.2 to 375 and 4.2 platform implants. Now, I like to call this the Eskimo technique because I just do a little tissue punch, place my implant, and then I place that soft tissue back over the implant and suture it up. Why the Eskimo? Because it's like cutting a hole in the ice to go fishing and then just putting the ice back on top over. And as you can see here, we've placed these implants, placed our cover screw, and I will show you just now. We just grab that soft tissue, put it on over, and suture it into place. The healing is impeccable. There's hardly any swelling. It's very clean and very nice for the patient. So once we placed all the implants, all the complicated implants, the easy implants first, then we went to our sinus lift, raised the flap. I used the classic osteotomy using a bone burr here with liquid refrigeration. I opened my window, keeping that the sinus membrane intact, and I placed 2 bicortical implants here. These are 4.2 platform implants with bicortical insertion at 40 newtons of insertion. And as you can see here on the image of the left, that is all autogenous bone. That autogenous bone has the best healing and regenerative capacities you can imagine. And all that quantity came just by placing all the other implants first. Why is this important? Because a lot of patients say, oh, let's just do implants one at a time, or let's do the left quadrant first, and then next month we'll do the second quadrant. And they think that that's easier for them. I prefer to do every single implant the patient requires at one single operative time, because it always allows me to harvest incredible quantities of autogenous bone if grafting is necessary. So here we managed to pack the entirety of the cavity with autogenous bone. And here you can see me using the bond bone, this calcium sulfate, bicalcium sulfate product, which is a binding agent. You can use it by itself, with autogenous bone, with BioOs, with whatever you want for scaffolding purposes. And I used it in this case as a membrane. And here you can see some gauze on the right, which I leave in place for about a minute to 2 minutes. And then as you press it very, very hard with your finger, it sets. It sets in the presence of blood and saliva. Here you can see the suture. I've just put that tissue punch, soft tissue, back over each one of the implants, sutured it into place, closed everything up. And you can see here my immediate post-op panoramic x-ray where we placed all those implants. So I got a lot of bone from these implants before doing my sinus lift. And here's the CT scan, or the cone beam scan after my implant placement. You can see, look, that's all the bone that I placed. And one of the advantages of the bond bone is that it's visible in the CT scan or in the cone beam scan. This is after 2 weeks. Look at all that beautiful soft tissue healing. Remove the stitches on the bottom as well. And we just used here a partial denture for the subsequent. We waited about 2 months in this case, and after 2 months, 2 to 3 months in this case, I think it's 3 months, the patient came. We just did tissue punch and placed the healing abutments to allow for soft tissue regeneration around that. And after a few weeks, the patient came in to take the final impression. So on the same day that we're taking the implant impressions, we prepped his natural teeth. You can see the preparation of those natural teeth here. The impression copings placed, the impression caps placed, everything in place, and we take top and bottom impression in one go. And of course, using the facial bow and using all the classical rehabilitation techniques, we do the build-up. And in this case, being a full mouth rehabilitation, we wanted to do a try-in in the mouth. Patient comes in for a try-in. We make sure we've got good clearance for good quantity of ceramics. And I'm not going to get into everything here, but here we got the final restoration. And as you can see, it is screw retained. This is something that I find always very important because of the retrievability. And here we have the structure screwed into the mouth and the holes filled up with the composite resin, and the final rehabilitation. As you can see, nice pink ceramics that were previously discussed with the patient. And here we can see the x-rays, everything in the mouth. And we go from this to this, and we have a very happy patient. Now the case, this is a paradigmatic case of, remember me talking about what's an easy case and what's a hard case. This is a very hard case. It looks easy from the beginning, but this is a patient who smokes 2 packs of cigarettes a day. As you can see, obviously has hygiene issues. Mobility of most of his teeth in the aesthetic zone. Very rude gentleman. He was rude to most of my staff. Very arrogant man. Had dental phobia. A very powerful businessman. And this are the kind of cases that you do not want to make mistakes with. Because, in all fairness, this is the kind of case that you should, just try and avoid at all costs if you are not an experienced clinician. But for those of you that take on cases like this, let me show you what we did. So we planned extraction and implant placement, but of course the importance of oral hygiene here was imperative. And we said, listen, you're probably going to have some failure because you're a smoker, and if you do have any implant failure, that's entirely your responsibility. We're not taking on any responsibility. We're not guaranteeing anything whatsoever in your mouth, sir, because you are a very, very complicated case. He signed every single document necessary, and we felt comfortable that we could go ahead. So we did all the whole hygiene, cleaned everything out, and in one stage, we took out all the teeth that had mobility and infections, cleaned everything out, and simultaneously placed implants. We did guided bone regeneration. This case was already about 4 or 5 years ago, so we didn't have bone at the time. But here you can see several types of implant: cylindrical, square thread, conic, tapered implants, different types of implants. And this was the case that I stopped placing square thread external hex implants due to this. I placed all implants on the same day, and this is a different system. But as you can see, after a certain period of healing time, when the patient came in, took the impressions, everything, we have the soft tissue modulation here from my temporary structure. Very, very important here. You can see that there's no bone loss around this MIS7 implant. Everything is perfectly in place, and we had a lot of bone loss to the first thread. And here's the case here: no bone loss at the MIS7 implant and bone loss around this external hex square thread. And that was the day I decided to stop using these implants. So once again, evolution is very important, and it's important that you stick with new trends. And a lot of colleagues out there are a bit lazy when it comes to new trends in the market, and it's so important to evolve. 2013, guys, so for those of you that are scared of trying new things, please don't. And here we have the final restoration. Now, why did I get, we got a result here that I didn't have to use pink ceramics. This staining on the bottom teeth is chlorhexidine staining. We brought him in, and we obliged him to come in every month for cleaning with the hygienist, and I explained to you previously how important that is. But look, we've got great soft tissue response here. He had a temporary structure in his mouth for 6 months before we decided to go into the ceramics. So we felt pretty confident that we'd get a good overall aesthetic result. The implants were placed at the right bone level, so on and so forth. So we're pretty happy with this result, and this is 4 years in the mouth now, and he's still got everything in place. So evolution is a process that requires trial and error, and a surgeon must make mistakes in order to grow. Now, I hope that those mistakes that people are making today are more based on what products they're using and not so much on surgical mistakes. Because, I mean, as I showed in the beginning part of my webinar today, that science has been out there for over a decade now. The positioning of the implants, we know all of that for a very, very long time now. We know how the body reacts. We know how the cells react. So I believe that, success comes from the treatment planning and case selection and using the right implants, using the right products. All of that together is going to register as, success or failure in your practice. So coming back to that analogy of a football team or of a Formula One team, if you want a winning team, every single thing counts. And it's so important to use the right materials and case selection. Here's a case that we did about 5-6 years ago. This patient, and this is just to go back to show a little bit about evolution. This patient came from very far away. She had to drive 8 hours to come to our practice. And an oral surgeon had decided to do a frenectomy with a laser and created osteonecrosis by mismanagement of the laser technology. And this is how the patient came to me, incredibly upset. We have a problem in the aesthetic area here. And as we can see in the initial panoramic, she's got divergent roots over central incisors and one implant placed, but quite frankly, she needed an implant here and an implant here, and had still roots left to be removed in her mouth. Her oral hygiene wasn't very good. I can't understand why a surgeon would want to place an implant and not clean everything up. And once again, this is a classic case of just bad patient management and bad treatment planning. And then people wonder why, some doctors are more successful than others. And it just comes down to just using your head and doing the right thing. So I didn't know what to find. And I told the patient initially, look, most probably you're going to lose your central incisors. I really don't know. And because she came from so far away, and I said, look, we have to clean that osteonecrosis. So no matter what, we're going to have to clean all of that. And we raised the flap and cleaned all that out. Look at the size of the defect; it's quite huge. And at the time, this is what we had at our disposal: was BioOS and the classic BioGuide collagen membrane. This is a special tack that held the membrane in place. These membranes, sometimes are very difficult to use. We could have used a titanium reinforced membrane. That would have meant that I would have had to go back in for a second stage surgery, which is not something that I really wanted to do. And we just sutured everything in place and did an immediate structure. And this is the 1 week post-op. Now, I expected this type of resorption, but these are little particles of BioOS coming out through the gingiva. Now, this is not an aesthetic result, but it is a lot healthier now than what she had when she came. At least the necrosis is gone. So this is, for me, day one of this case. And I started thinking, and I sat with my team, and I was like, what can we really do here? And this is why it's so important to go into the literature and understand what is out there. And what we did with this case was, I said, look, we can extract these two teeth and do a block graft. There's some great cases out there from Morris and Salama and David Garber and the team at Atlanta. These guys are some incredible work. And I was like, well, let's try that. But why don't we give these teeth a chance? Let's see what we can do. And this is the importance of having a good team. And I spoke to my orthodontist. I said, listen, let's try and do some orthodontic extrusion of these teeth and see what happens. So over a period, we did the root canal of the teeth. And we decided just to bring these two teeth together and try and extrude them a little bit. And after 14 months, every month she'd come in and we'd lower them about 1 millimeter, shortening these teeth at every time. But once again, we placed implants in the posterior region to give her good posterior function. Remember, posterior function is very important when you're working in the aesthetic zone. If you don't have teeth at the back, none of this is going to work. So a lot of patients think that this is a sales pitch. Oh, you just want to place more implants. You just want to make more money. It's very important to explain the importance of posterior function in any treatment in the aesthetic zone. So after 14 months, we removed the braces, the orthodontic appliance, and prepped the teeth to place a temporary structure. Now, what we've discovered was that, what I discovered here was that these teeth had absolutely no mobility. So I said, listen, let's just stick with these temporary crowns for, a good while. And I think she stayed with about 5-6 months with these temporary crowns in her mouth. But once again, I rebuilt that posterior function by placing implants in the posterior regions, giving her good occlusal support, took off all the pressure off these anterior teeth. I couldn't have done that if she was missing these teeth at the back. So it's not a sales pitch. It's not marketing. It's a clinical requirement for long-term success in the aesthetic zone. After 6 months, we took out these temporary crowns, prepped everything, and put in full ceramic crowns here. One thing I did do was fuse the two central incisors together, not only to augment stability, but to lower the contact point as possible, because I know, according to Dennis Tarnow, from that contact point to the crestal bone, which I knew was missing, if I had 5 millimeters or less, the papilla would always be there. So I trusted the science, I trusted the literature, and we have, after a year, a very, very stable result without any complicated surgery. So use the armory you have. You know that recipe book I told in the beginning? The more you know about the science, the more you know about studies. That's why Dental XP is such a great milieu, because you get to learn stuff from, a lot of great surgeons. And, here's something that appeared to be a very complicated case, and with correct treatment planning, and patience, we got a very good overall result. So let's apply everything we know at once. Here we have the case of a young chap who's got some dental crowding. He lost his central incisor. He has an increased overjet, as you can see here. Now, he wants an implant in this tooth. Now, he said, oh, just do it today. I can very easily place an implant in that area right there. I could use a narrow platform implant, and he could have a tooth on the day. Immediate loading, done. Would I be doing the right thing? So the question is, do we take a shortcut for an immediate gratification, or do we take the long road and give this young man exactly what he needs, which is a beautiful smile? Now, we all know how hard it is to communicate these complex cases, because this gentleman needs orthodontics. He needs, a lot of pre-treatment before we can go in and get that ideal spacement. So, of course, we did that. And Dr. Alessandro Curto from my team, who's been working with me for 10 years, did the orthodontic treatment here. We glued the crown to the bracket, did some expansion, and over quite an extensive period of time, we got the ideal width for our implant. Remember the beginning of my lecture where I spoke how the importance of the width of implants in the overall aesthetic outcome is. So this is a little something that we do. We don't wait to take off to finish orthodontic treatment before we place the implant. We knew he had about 4 months left of his orthodontic treatment, and that's when we went in. But we had enough mesiodistal spacing to place our implant, and that's when we went in and placed an implant. We used a tissue flap technology, placed our implant with an ideal torque. We put the soft tissue back over the implant and went on with the orthodontic treatment. Now, we waited a few months, and once that was ready, we decided to create gingival modulation with a temporary crown. And by the time this patient was ready to remove his orthodontic treatment, we placed not just the crown on the implant, but also on the central incisor for symmetry. Here we have the zirconium abutment and the crown and the prep of the adjacent tooth. And for symmetry and aesthetics, we placed the 2 central incisors. And here we have a bit of hemorrhage just on the day of placement. And here we have, after 15 days, you can see the soft tissue has fallen into place. Beautiful adaptation. Once again, this has nothing to do with the implant. This is to do with the quality of your lab, the quality of your impression, the quality of your impression material, the quality of the ceramics, so on and so forth. So everything counts here. And here we have, after a year, everything in place. Beautiful case. Look, we managed to bring all of that overjet back. None of that would have been possible had we not done the right thing. So we're coming towards the end of our webinar, and a few more cases here. This is a case that was done by my team. I placed the implants on this gentleman who had been using a partial denture for many years. Classical case, tissue punch. Here to place these implants. Look how that final burr from the MIS system that comes with every implant that they give you. Look how much soft autogenous bone you're going to get there. It's amazing. Here we're placing our implants straight through the orifice. Once again, I felt very comfortable to place these implants because of the biotype. I had thickness. I felt very comfortable with that. And we put the soft tissue back right over it. Here you can see, suture that into place. And he had some tooth extraction and implants to place in the posterior regions. We do that all at the same time. Now, you can see here, the neck of my implant is showing because I do not put that implant more apically because I want my implant to be at the ideal bone level. What I will do is graft around it. Here we're using a mixture of MBCP and BioOS and the collagen membrane. This is an old case because today I would be using bond bone. I would not be using this membrane. All the implants placed in one go on the day of impression. Note that one of these implants is not the MIS7 implant, hence it doesn't have the impression coping, the impression cap here. And this is how we do a metal try-in. make sure everything's in place radiographically. And in this case, we offered the gentleman a lower partial denture, a new one, because we wanted good occlusion. And this was very, very important. Note that everything's screw retained. No pink gingiva. Why? Because we did the low aesthetic risk option of implant placement for the classic 4 implants of missing 4 teeth in the front row. Had we gone implant, 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 I doubt we would have had this result. This is the easiest solution. But once again, he had very good soft tissue. If he had had very thin soft tissue, I would have probably factored into my treatment planning pink ceramics. So it's not always, you know, a great surgeon, oh, I'm better than you, or I've got better results than you. I didn't have to use pink ceramics. Pink ceramics doesn't mean you've had failure. It means you've actually diagnosed correctly your patient and factored that into the treatment planning before you even start, based on biotype thickness. And here's the overall outcome. Very stable results. And now, of course, this gentleman wants to do the bottom. Here we have a client who everything was in place, but she'd had orthodontic treatment done, and she was also she sucked her thumb quite a lot. But as you can see, you know, she's missing some teeth here, but she had posterior function. But if we take a closer look, she had rejected her 4 central incisors. I mean, these teeth had complete mobility. She'd had resorption of all the root, and these teeth had completely failed. So in this case, atraumatic extraction to keep the papilla. And for those of you that were paying attention to the beginning of the lecture, we could have placed many different options. We could have placed an implant in each extraction socket. We could have placed implant, yes, implant, no, implant, yes, implant, no. But we went for the classic solution, which is implant in the laterals. We had the placement of the MIS 7 implants with a 45 to 50 torque insertion. We did some bone compression of that buccal plate over here. Why? Because that was quite protrusive in this case. And as you can see in the x-ray here, we compacted that with some bio-os to create a more slow resorption pattern. As we know, bio-os has up to 6 months for its turnover rate. And it creates some good bone scaffolding here. Because had we not done any grafting, we know that we would have lost up to 50% of bone volume in the subsequent year. And I didn't want that to happen, and that's why we did the grafting. And in this case, because I had such good insertion torque of my 2 implants, here we can see a little bit of a collagen plug placed in place. I sutured everything in place. And I used her natural incisors, and I'll explain how I did that. I put some cellophane, kitchen cellophane, over my, my surgical site. I injected cold cured composite around everything and put her natural teeth in place, and then just manually built up a structure. And as you can see, the cellophane protects my surgical site here. And here we contour it, creating a ovoid pontic to allow for a more natural appearance, and screw that into place. And over a period of time, as a 1-week follow-up, now, I wasn't very happy with the aesthetic result here, and I knew that I was going to need a little bit more to get a good aesthetic outcome. So, over a period of time, she would come in and we would remodulate those ovoid pontics, creating more emergency profile, keeping everything smooth and highly polished. Very, very important. And doing that, we created a more natural result. So, we removed these provisionals, put in our impression copings, and took our impression. And one thing that we did at the time was we used a cauterized electrobistry to create the illusion of a margin here. Took our impression, sent that to the lab, and here is the work in question, screwed into the mouth. And look how we brought that all back. And no requirement for soft tissue. Why? Implants were placed in the right area. She had very good volume, but we also did that grafting at the time to keep that soft tissue in place. Now, everything indicates that this will be a very long-term and predictable outcome. What we did as well was we augmented her upper lip just to give a bit more of aesthetic result here. Different countries have different regulations on the using of hyaluronic acid for lip augmentation. We feel very comfortable doing that here in Portugal. If you're not allowed to do this in your country, I suggest that you find a good dermatologist or plastic surgeon that can work with you on these cases, because it really does boost the overall results. And at the end of the day, guys, we're also into sales, and we're also into good business practices. So if you have a happy customer at the end of the day, she'll bring back 10, 20 more customers for you. And this is the last case. Carmen is a very good friend of mine, and she came in, and after using a partial denture for many, many years, look at the natural hyperplastic soft tissue here, just to irritation over many, many years of using these. Very, very complex case, very little bone, but according to the No Half Smiles philosophy here, we did some good treatment planning, decided to do full mouth rehabilitation, and in the aesthetic zone, this is what we did, since this lecture is on the aesthetic zone. Very, very thin bone. So what I used here was the ridge expansion kit that MIS have. This is not a burr. Basically, we used the pilot drill, which is a 2mm pilot drill, just to orient, just to give us the right orientation. And then what we do is, this is a ridge expansion kit, which is used mainly for sinus lift, but I don't want to destroy, I don't want to remove that bone. So what this is you do it a very slow insertion, and what it does is it expands the ridge. And here we have, after that expansion done, I'm placing these narrow platformed implants from the MIS7 system. These are 3.3 bodied implants, and they're 13 millimeters long. And we place it into the bone. These implants are incredibly aggressive in the way they go into the bone, and they also expand the bone. And I got a wonderful 40 Newton torque at the time. Now, you can see here I've placed my implants, and these adjacent crowns have not yet had root canal. There's no active infection, but there's no way I'm going to let that happen. Dr. Carlos, on the day that she comes to remove suture, will do the root canal on these crowns. On these roots. Now, one thing that I wanted to do was, I know that after placing these implants, that there's the possibility of resorption of that buccal plate, because I did not have what the literature says is ideal, which is those 2 millimeters. So what I did was I mixed a composite mixture of bio-os and bond bone. A composite mixture is 2-to-1 ratio bio-os bond bone, and I built up that buccal plate. And then I just used a pure layer of bond bone over that. And soon I will be placing a lecture online, a very small 30-minute presentation on what bond bone is. It's a great product. And as you can see, we also place an implant down here. Here we have, you can see the bond bone in the 3D cone beam scan, and the placement of my implants bicortically, perfectly placed, and how we built up all that buccal plate there. Now, this is a 2-month follow-up with a temporary acrylic crown, bridge, and we waited to make sure all that soft tissue and hard tissue stabilized. During that period, we did the root canal, we did post, we have these carbon fiber posts, and on the day of the impression, we prepped all the teeth, exposed those implants, took our impression, and here's the final rehabilitation. What I want you to see is this is about 7 months after the surgery. Now, according to studies, had we not done any grafting with the rebuilding of that buccal plate, I doubt we would have had such wonderful results here with the soft tissue. And of course, once again, the importance of posterior function. Root canal, all the new root canals done in the posterior teeth, crown and bridge work done here. This patient is also a chronic smoker, which I failed to explain. That's why we didn't go into the sinus lift over here. We kept things very simple, but the importance of posterior function and This is after a few months. You can see quite stable results. And let's look at a 18-month follow-up. Look at all that soft tissue. That biotype is all still there in place. We know that that first year is critical. So 18 months is well over that period. And you can see here, the buccal plate is still all there. So I know, I mean, in my experience is that most problems will appear in the first 2 years. So I'm quite happy. And this this CT scan is already about 9 months old. She came in recently for a cleaning, and I must say that still very happy with the results. And you can see here the evidence. So once again, very good use for bond bone here. Very simple, very easy to use. So I'd like to thank you all for listening. These are Dr. Inês Miguel. She runs the aesthetic department in my clinic. Dr. Ricardo Vieira Alho and Dr. João Moral, who are both implant surgeons and help me with oral rehabilitation. Dr. Carlos Moraes, who is our endodontist, and missing Dr. Alessandra and Dr. Susanna and Dr. Danielle on my team that helped me do this. And I hope that this wasn't too long, but you know, it's very hard to discuss just one element of success. It's not just the people you work with, it's the choices you make, it's the materials you work with, it's the lab you work with, it's the quality of your implant, but most importantly, you know, the treatment planning. So the more tools you have at your disposal, the better quality everything is, from A to Z, the more predictable outcome you'll have, and I believe more success in your practice. So thank you all, Happy New Year, and I hope to see you all again very soon here on Dental XP.